everybody, and welcome to the Pompe Alliance Town Hall. We're honored to bring together patients, caregivers, advocates, and industry partners for an open dialogue that centers around the lived experience of those affected by rare disease. This town hall is a space for collaboration, education, and empowerment where your voice helps to shape the future of care, advocacy, and community support. With that said, I would like to introduce our wonderful panel. We are really excited about the panel that we've put together. The people here have lots of experience and come from different backgrounds and have lots of expertise. So we're very excited to have them with us today. The first person I'm going to introduce is John Brad Dean, and he is the Constituent Services Liaison for U.S. Representative Shontel Brown. Shontel Brown is a congresswoman from the state of Ohio, where I live. The second person, I'll go through everybody and then we'll go back. The second person is Paloma Juarez, and Paloma is a mother of three sons, Vaughn, age 9, and twins, Cohen and Xavier, age 5. Vaughn and Cohen both have IOPD. Paloma has worked with Every Life Foundation and is completing her second year with the Rare Disease Legislative Advocate Committee. Next is Erica Barnes. Erica is the executive director of the Minnesota Rare Disease Advisory Council. The next is Dr. Paul Howard, and Paul is the executive director of public policy and corporate affairs at Amicus Therapeutics. And last but not least is Bailey McGowan. She's the director of policy and research at Every Life Foundation for Rare Diseases. So I'll go back to you, John, if you want to give us a brief introduction.
Sure. Thank you very much for inviting me to join the call. As you had stated, I work for Representative Shontel Brown. We're based out of Cleveland, Ohio here. I have been working for Congress for about 19 years now in a constituent liaison role. So essentially what that means is people call with individual problems, and I do my best to solve those individual problems. So I have been around since the inception of the Affordable Care Act. I got to see it through the campaign and all of the different versions of it through the bills, and now 15 years on, seeing how it continues to this day to help people. So hopefully I'll be able to answer some questions and concerns in regards to the new budget bill that has gone through. And again, thank you for the opportunity.
You're up, Paloma.
Hi, my name is Paloma Juarez. I am here in the great state of Kansas, just outside Kansas City, in a suburb called Prairie Village. Like Heather said, I have the joys of my life, my three sons, Vaughn, Cohen, and Xavier. Vaughn's diagnosis was devastating, but very eye-opening to some of the possibilities and the pieces that fell into place to make his story one of really extraordinary outcomes. He was flagged for his newborn screen back in 2016 in Missouri. Missouri was one of 5 states at the time actually screening for Pompe. Because of that flag, we were able to get a diagnosis by 10 days of age and then started enzyme replacement therapy at 23 days old, which in 2016 was not even something we thought possible. Today, he is a 9-year-old that does all of the things. He scored a touchdown playing flag football on the recess the other day that he was so excited to come home and tell us. He's a very independent, brilliant little boy. And so that really led to me and my husband and my family jumping in and wanting to be advocates for newborn screening. We've been a part of that since forever, it feels like now. And to see where we're at 10 years later, almost since the inception of Pompe on the RESP, to see that we will be screening for 96% of births here in the United States just saying that out loud feels really emotional and heavy. So Really excited to be here and talk about our experience and how sharing our lives and our small victories really can impact your ability to see change. So thanks.
Thanks, Paloma. Erica, you're next.
Well, first of all, so happy to hear that you're from Kansas, Paloma. I was born and raised in Kansas, so now I'm in Minnesota, Minnesota transplant, but shout out to my home state. I'm Erica Barnes. I'm the executive director of the Minnesota Rare Disease Advisory Council. We're actually an executive branch state agency, small state agency here in the state of Minnesota. I'm a speech pathologist by training, and prior to my work as the executive director of the council, I was in advocacy. I had started a nonprofit for my daughter, in honor of my daughter, Chloe, who passed away from a rare disease. The Rare Disease Advisory Council focuses on improving care and access and treatment for people living with rare diseases in Minnesota. So excited to be here and learn from the panel.
Thank you. And Paul, you're next.
Thank you very much, Heather. Paul Howard, I'm Executive Director, Public Policy at Amicus Therapeutics. I'm here today in my own capacity, just speaking as a policy expert and a member of this community. And I'm taking the perspective of someone who's worked in health policy for, I guess, about the last 20 years. I've been at Amicus Therapeutics for 6 years now, and I came over from the U.S. Food and Drug Administration, where I served as a senior advisor to FDA Commissioner Scott Gottlieb from 2017 to 2019. So I bring a variety of perspectives, and I've seen, all the parts of the U.S. healthcare system, and it's really not fair to call it a system because there's nothing systematic about it. It's incredibly fragmented. But Medicare, Medicaid, private insurance, and then, of course, how that interacts with the services and medicines that everyone needs to stay healthy and achieve the best health outcomes we can for ourselves and our loved ones. But thank you for inviting me today.
Thank you. And Bailey.
Hi, I'm Bailey McGowan. I'm with the Every Life Foundation for Rare Diseases. I'm our Director of Policy and Research. So for me, that means a lot of regulatory tracking and sort of seeing what's going on with the agencies, and then working on some of our data policy projects, and figuring out the best way to sort of combine that with what's going on in the regulatory and access space to sort of paint the best picture and do the best advocacy work we can. Every Life Foundation, for those of you who don't know, we're a nonprofit that focuses on empowering advocates to do their own advocacy work and helping provide the tools to move forward evidence-driven legislation and policy.
Thank you. So my first question is for Paul. What specific provisions in the current budget bill do you believe pose the greatest risk or opportunity for rare disease patients?
Thank you. And I'm just going to tee this up for the whole panel to discuss because there's so much material here, but maybe I'll just lay the framework. And again, I'm just speaking from my own perspective, so apologies if I miss anything. The bill that we're talking about, it's either HR 1 or you can also refer to it as the One Big Beautiful Bill Act. For our purposes, what it did over 10 years was reduce Medicaid and related healthcare spending by over $800 billion. And there are a couple of provisions that I'm concerned are going to impact the rare disease community, both adults living with rare diseases and families. And they're primarily related to provisions that impact what are called the expansion populations. So there is the classic, before the Affordable Care Act, Medicaid populations, which were traditionally pregnant women and children, the disabled, and some other special populations. A number of states, I forget what the exact count is, but let's just say a great many of them expanded above traditional Medicaid with additional funding that the Affordable Care Act provided to expand coverage to those populations and cut down on the number of uninsured in the US. What the reconciliation bill does is it has a number of new work requirements for expansion populations, a number of eligibility verification requirements for expansion populations. And it also puts caps on a lot of the ways, or some of the primary ways, that states have used to draw down federal funding for additional services and supports for rural healthcare, for rare disease center of excellence, and other specialist providers. And those are called provider taxes. And I won't get into that. It's kind of complicated. But I'll just say that states are going to be handcuffed in how they can use those funds, and those funds are going to be capped going forward. And then we also have the fact that Congress is allowing the expanded premium tax credits that first took effect, I guess it was 2021 during COVID, to help people maintain insurance while we were all required to stay home, basically. So those tax credits are expiring. And they don't expire till the end of this year, but we're already starting to see some of those impacts on the cost of premiums for the benchmark, what they're called benchmark silver plans. And states are going to spend the next year um, creating new rules for eligibility verification and for work requirements for those Medicaid expansion populations I spoke about just a few minutes ago. Now, I will say, and I'd love for Bailey and others to jump in here, there's an old joke in health policy that if you've seen one Medicaid program, you've seen one Medicaid program. They're all different. They're often unique in many ways. And I think one of the real challenges that the community is going to have over the next year, whether it's for the ACA exchanges, whether it's for these eligibility and work requirements and re-verification requirements, is to understand exactly what every state is doing, to engage policy partners as much as possible, to educate them on potential impacts on our populations, especially through, and I think Erica, the RDACs are going to play a critical role here in helping state departments of health understand how these new rules are going to impact vulnerable populations and what we could do to offset them. And the last thing I'll say before I hand the baton over to my colleagues is that there are some small offsets in the bill. There's a $50 billion rural transformation fund in the legislation. This is a drop in the bucket compared to the $800 billion that are essentially going to be coming out of it. But it does encourage the states, I think it's $10 billion over the next 5 years between 2026 and 2030, to apply for these grants for healthcare transformation, telemedicine, and some other supports that could be quite useful, even if they're somewhat limited. But let me stop there and let other people weigh in.
Thank you.
I'll tag in a little bit on maybe something else to look at, which is just the administrative burden that this is going to place on the states moving forward and trying to figure this out. And not to be too much of an optimist about it, but it does at least present a really unique and different entryway for advocates to get involved in their states. And it provides like the perfect conversation to sort of start teeing up and doing that education in that ground setting and that level setting. We've heard from a few states so far that have already previously implemented work requirements or tried to do so. So I think, to echo Paul a little bit, it's going to be interesting to see maybe what lessons learned from states we'll see and how each state is really going to do this, because one Medicaid program really is just one Medicaid program.
Yeah,
Brad, do you have something? Oh, I'm sorry. Go
I'll-
ahead, Paloma.
I'll hop in. So the analogy that I like to use is we talk about newborn screening, and not one newborn screening is really the same. You as a state get to dictate what that looks like, and that is the same for a Medicaid program. I think with so much heaviness and feeling all of it, trying to like look at things in a positive way. Um, this does give us as advocates an opportunity to talk about healthcare in a way that doesn't make it, we talk a lot in terms of too big to fail. With healthcare in the United States, often the conversation from senators and representatives that I've had is, well, it's too big to fix. And I think we're at a point in place now where we understand that it is likely about to fail in ways that we generally didn't know possible. And so that opens up conversations and opportunities to really collaborate and use real life experience to talk about is this no longer too big to fix? Is this now a necessary thing that we need to fix? And so there's ways to drive those conversations now, whereas before it really just kind of felt like stay in your lane, in your place. Like we appreciate what you're saying, but I think now very much so understanding the nuances and experience of folks is going to be really, really important.
Thank you,
Yeah, and
Paloma.
yeah, sorry. And if I could kind of build a little bit on what Paloma said, I think just taking it and certainly I know there's some conversation still about the technical aspects, but one of the things we did in Minnesota is, and I think we got in on the beginning before they were overwhelmed, but we did ask our DHS to come in and talk to the rare disease community at a legislative forum that we had, and then we asked them what would be the best way to give them feedback as a DHS and give them tell them stories of how, because in some ways we're not going to know until it starts happening what some of these impacts are. I think that's pretty obvious that it's going to be difficult to tell. And of course, as we know, some of these provisions are going to roll out in 2027. So really just one of the goals that I have as RDAC is to really get a structure in place so that we can start giving feedback to the right people as we see these impacts. So they can be responsive. And I will say another sort of concern that we heard from our DHS is the limit on the 3% error rate. That so if there are overpayments or erroneous payments, as the states are in such a position that they're going to be trying to figure this out and who's eligible, who's not eligible, and the one big area of concern to us, one of the areas is this cap, the 3% cap on the ability of the feds to waive the errors, any fees due to errors. So to me, that when something's so new and so difficult to figure out, that's just it feels really kind of punitive, and so that's one of the concerns. But we'll just as a RDAC be ready to sort of be able to give some of that feedback as we're able.
Heather,
Yes,
we have a question.
I see. I'm going to let Brad respond, and then we'll go to Becky's
Well,
question.
read the question. Oh, okay. Okay,
Yeah, I'm going to
go
let
ahead.
him respond to the first question, and then we'll go to Becky's question.
Excellent. Well, I appreciate everybody's response. As of yet, I can certainly give a bit of a recap on all that. Really, as far as Medicaid goes with the work requirements, this is going to create a lot of uncertainty and churn and burn. I know in Ohio, this is going to have to be re-upped every 6 months. And every time you have to submit paperwork to an agency is an opportunity for your coverage to get dropped. Another change that happened in the marketplace is it used to be auto enrollment. So if you enrolled in the plan 1 year and you liked it, you didn't want to change, you'd be auto enrolled into the next year. That is going away. So that's just another opportunity that you could potentially lose coverage. Something for either the patient or the caregiver to really consider every single year, or in case of Medicaid, every 6 months. So that's unfortunately it's these kind of things that seem to be placing gates in front of care rather than creating access to care. Another thing that was not mentioned yet is the orphan drug negotiation exclusion. So we did, through the Obama administration, get a historic development of drug negotiations under Medicare. That was only an initial 10 drugs that for that first year. They were going to do another 10 the second year. But as I understand it, this bill actually delays or excludes more of the of the the orphan drugs or the more experimental drugs overall, whereas they were not before. And certainly, as everyone knows, those are extremely expensive. So it would be really great if we could negotiate those prices, but unfortunately, it seems as though some of those are going to be leaving that category.
Thank you. Becky's question is, do we know currently if there will be any exemptions for those living with a rare disease, who may have Medicaid as their insurance, but are unable to work and thus not able to seek employment or need to reapply even if diagnosed with a debilitating, even terminal condition. Bailey, can you answer that question?
And someone please correct me if I'm wrong. I don't think there's any current exemptions specific to rare diseases. There are a list of exemptions out there. I just for anyone who's looking for some resources and maybe something really easy to understand on your own time, Georgetown does a great job of putting out some information, and so does Kaiser Family Foundation or KFF. All great resources on looking at exactly what those exemption provisions are. I don't know them off the top of my head, but some do exist.
Thank
And
you.
this might be an excellent opportunity to advocate. If you do have a specific rare disease, I mean, to make sure that your Job and Family Service office or Medicaid office in your state is aware of the community and the need.
And one great avenue to do that, just to tee up a little bit of some states implementing a rule from CMS last year, is states are implementing beneficiary advisory councils or committees for their state Medicaid programs. A lot of applications are open, some of them are on a rolling basis. But what these councils do is they get together a population of the Medicaid, of their state's Medicaid population. They get together a group of applicants to chat about certain aspects of it. So what's your experience with Medicaid? Work requirements will be one of them. Michigan actually reopened their application once HR1 passed to allow their citizens in their population to apply and join that committee. So definitely something to keep an eye out on. We're trying to put out information as we find that. And then also if anyone just has questions on their application or how exactly a BAC works, if your state doesn't have a ton of information, happy to be a resource.
Bailey, can you tell people where they can find the application for that
It depends on your
program?
state. So each one
Okay.
is run through your state. So if you search, Minnesota Medicaid Beneficiary Advisory Council or Committee or BAC, you should be able to find information on that and then the application linked with it.
Thank you. Paul?
Thank-
I see you had your hand up, Paul. I'm sorry, Erica.
No, I'm sorry. I will start raising my hand too. By unmuting, raising my hand, there's a lag time. Go ahead, Paul.
Oh, thank you, Erica. I was just going to say the other population that this could get challenging for are dual eligibles, people who are both for qualify for medical reasons for Medicare and also have Medicaid coverage. And the issue that Brad spoke about a little while ago about the churn is a real concern. You could lose Medicaid coverage potentially for the services you get, even though you're going to maintain Medicare coverage for, for instance, any medications you might need. And I'm gonna plug an Every Life Foundation study that's really good. It's the diagnostic burden study, I think it was, Bailey, from a year or two ago. I think one of these assumptions out there is that our populations are major cost centers for the states. I think the reality is not that rare and orphan diseases are actually quite a small part of state Medicaid budgets, but one of the things that the study, the diagnostic study, and there's other studies from the Every Life Foundation that are worth talking about, found if you can get a patient to an earlier diagnosis and maintain appropriate treatment for them, you can avoid wasted and unnecessary care, and then potentially keep that person in the best health state that you can if you can get them on an appropriate therapy, assuming there is one. So I think there's an opportunity for education there too. That allowing people to go in and out of coverage or in and out of treatment is really going to wind up not only being terrible for them and their families, but it's going to wind up costing the state more in the long run.
And Erica put a link to the burden study in the chat. Thank you.
Yeah, and I love what Paul said and just, for advocates to have those resources to share with their legislators. I think one thing we really emphasize is and Bailey, I think Every Life does some webinars to kind of keep people updated on this. Am I correct? I just really encourage everyone to find an organization that you can plug into that's doing advocacy so that when it's time to share this back, we're ready for that. I know we've talked about some of the coalitions. I think there's a coalition called This Is Medicaid, at least there is in Minnesota. And it's a coalition of a lot of different organizations who use Medicaid. And part of the value of that is, and part of the goal of the This Is Medicaid coalition is to really help the public understand who exactly uses Medicaid. What is it used for? As you know, we know that Medicaid is for low income folks, and which is wonderful, but some people in the public don't realize that people with disabilities also use Medicaid. And so some of that is educating the public as to who's going to be impacted and how they'll be impacted.
Thank you. This next question I'm going to ask to Brad, as you've had some experience working in the ACA marketplace. Can you talk a little bit about how the budget is going to impact people who are receiving their insurance through the ACA marketplace, as well as people who might be receiving SNAP?
Certainly. So really, right now, the big fight is over these expanded benefits, and these expanded benefits were for folks. Really, it's going to hit folks mainly that 50 to 65 years old. They are above the poverty line, but only slightly. And unfortunately, this is already an older population. So not only are they going to lose that subsidy, but they're going to find that as an older population, they have higher healthcare costs. Overall, what we shall see is a disappearance of about 75% of that subsidy. So this, we might have all seen news stories in regards to this. We're seeing folks' bill go from 200 to 1,000 or 1,200 in some cases. This, I don't think, is going to be contained to just the marketplace. Although the marketplace is the one that's most directly affected, essentially these are for-profit insurance companies, and they are going to need to make up their balance sheets elsewhere. So although I don't believe it has hit the Medicare market quite just yet, I do anticipate all prices to raise for even folks that are getting it through their employer or through Medicare next year, as these insurance companies are trying to balance their books. So although it might be contained to the marketplace this year, I do believe that we're going to see it across the system in the coming years. Certainly, we discussed the work requirements. Really, the SNAP benefits as well, they're going to have those work requirements and those waiver requirements. And again, as we mentioned, there is a lot of potential for folks being dropped as they're attempting to work with their county agencies to ensure that they're getting all their paperwork in on time twice a year, to make sure that they have their I's dotted and T's crossed. But again, we know how bureaucracies work. Sometimes that doesn't always work. So we do anticipate folks to be dropped from these programs and bureaucracy problems to happen. So overall, I really do believe that this is going to lead to a weaker system and a denial of benefits, whether that be folks just deciding healthcare is too darn expensive, and not choosing to get it, which leads to another problem. I apologize to tack this one on there, but the more folks that drop off the insurance plans, the higher the costs are for everyone else. So if you're looking at sticker price and you're saying, I just can't afford it, once you drop off, if we get a whole lot of people dropping off, the prices are going to rise, and then more people are going to drop off. And that goes into what we would refer to as a death spiral. And I believe a bit of what Paloma was referring to as well, is that this is not just a one-time problem for this year. This could potentially lead to the overall collapse of the insurance market, which is a scary sentence to say, but unfortunately, what I could foresee happening unless solutions are presented.
Thank you. And so, Paloma, I want to go to you next as a caregiver. What do you feel are the real world consequences of budget cuts or policy delays for families managing rare diseases?
It, you it feels mortal, right? You think about all of the things that had to go right for an infantile onset child to not only just live, but thrive. Um, we had to find a treatment. We had to have accessibility to said treatment. You had to have a newborn screening program, and how long did it take to get that across the country and have access to that? Um, and so all of these amazing things fell into place. And then to know that all of that could be lost because, to Brad and everyone's point, um, could insurance become priced out? And now am I in a position to think in real terms of, do I have a place for them to live? Or am I making sure that we have access to a $2 million treatment each year, right? Um, I think those are heavy, hard choices for families, and families that maybe have 3 or 4 other kids that aren't relying on this the same way. How do you make those decisions? It is, for our family, we've always known insurance is a matter of life and death. And so we've made career choices, location choices, choices in our lives to make sure that our children will always have access to treatment. And while we are incredibly privileged and sitting in a very safe place right now, that may not be the story for our Pompe friends and family, and that feels really unfair.
A follow-up question. What support systems or policy changes would make the biggest difference in your day-to-day caregiving experience?
Wow. I think just a matter of feeling heard, right? I think there's always these wonderful ideas. Would Medicare for all and not having to think about the idea of insurance take a burden off? Well, yes, absolutely, right? Um, does that allow my husband and I to go chase our passion in entrepreneurship because now we would have access to care for them always? Those are all great things. As you go further, though, and talk to friends across the pond, right, that have these state-run free insurance, right? There's also this feeling of them giving feedback. Well, you can go to Duke anytime you want to because you're allowed to with the insurance that you pay for. So then that gets you thinking, like, as new treatments become available, like, am I going to have access to that? Or is the government going to say, nope, you only have access to the one enzyme replacement therapy? So there's always the grass is greener on the other side. Where is the middle ground? But I think really being allowed to be a part of that process and be represented in a way that is actually representative of us, and having those conversations that, while yes, having a Medicare for all plan is fantastic, how do we maintain the opportunity to have options and be a decision maker within your own care, I think is really important too. So I think just being at the table and part of the process, I think, would mean a lot.
Thank you, Paloma. I think Paul had his hand up, and then I'll get to you, Erica. Oh,
almost 30 years
Let
ago.
Erica go. I've already talked too much.
okay.
You're just faster than I am. Kind of building on what Paloma was saying about, the absolute vital services and needs for family that are really a matter of life and death. I know one of the services that comes up a lot in Minnesota with the rare disease community is access to PCA care, and how that home health care often, we've seen historically that PCA coverage, when budgets are squeezed, that seems to be one of the first to go. And yet that is just so vital for families to be able to, let their children go places, go to school, or for families to be able to have some respite or to be able to work out of the home. Having those PCA services can mean that somebody stays employed versus having to drop out of the workforce and stay home with their child. And I've seen both situations, right? I've seen families with PCA services who could continue to work, and then I've seen people who've had to drop out of the workforce. So I think, in terms of the specific services that are on the minds of some of the patients I'm talking to, it's really those home care services.
Could you clarify what PCA care is?
Sorry, personal
That
care
was
attendants, folks that can come and take care of children. So I'm speaking more to the pediatric population, although I mean adults get that care too, but sort of that care that's provided in the home. Thank you.
And
Sorry,
that's
acronyms.
an interest. I'm glad you brought that up, Paloma, because I've talked, or I'm sorry, not Paloma, Erica, because I've talked to moms in the Pompeii community about this type of care, and I've always been told I would never leave my child with someone I didn't know,
Mm,
because I always want I had thoughts about how could Pompe Alliance do respite care for parents, because I know that's really important. But I never. I'm an adult with Pompeii. I couldn't. I could not imagine leaving my medically fragile child with someone who may or may not be trained in how to take care of them.
yeah,
So
and
thank
and
you for
that's
bringing
such
that
a
up.
yeah, and that's such a good point too, Heather. I know in Minnesota we've worked really hard to um, advocate for better training of these personal care attendants, better pay, so that we're drawing a more skilled workforce. That's a really good nuance that you're bringing. So one of the things we've advocated for, and I just give a huge shout out to the Minnesota Council on Disability, kind of my partner agency that's really done a great job advocating for those things, so that we are getting qualified folks that have skills and paying for them to have continuing education. So yeah, really good call out.
Thank you. Paul, did you have something to add?
It's just, listening to Paloma and building on what Erica just said, and this is in every healthcare system, you face two challenges, one of which is bringing everybody up to the standard of the best available treatment and care and support that we can give them. And then finding a way to push the cutting edge forward so that the next generation of innovations can come and offer whatever that advance is. And hopefully we get to the point where we have more long-term, potentially curative approaches the way we have for HIV, AIDS, um, for cystic fibrosis, other diseases. By the way, we don't make any of those drugs, so I have no conflicts there. But just to say that we kind of have to think of both. And I think where we often run into trouble is we think about what we do in silos, whether it's a treatment or it's supportive care or it's insurance coverage. And the reality is we have to look at things really holistically, because oftentimes we've pushed down on one part of the balloon and the balloon just comes up on the other side because people don't get the care and the services and supports they need. And optimally, what we're trying to do is ensure that, especially people who have or are going to be living with serious chronic long-term conditions like rare and orphan diseases, have the absolute best possible lives and live the fullest lives they possibly can. And we have to step back and look at the whole picture. But I just wanted to say that.
Kind of
Dorinda, oh, I'm sorry, go ahead.
kind of building a little bit on what Paul said in Paloma in terms of sort of the development of new drugs. I think one thing we also haven't talked about is some of the impacts on the FDA and the NIH, and specifically for the rare disease community, some of those, I think especially the reduction in workforce. I know there's some communities that have already said their PDUFA date has been pushed back. So their date of for our industry partners, their drugs being reviewed and approved, some of those dates have been pushed back. At the same time, I do have to say that, at least from my perspective, and maybe there's different perspectives on this call, I do think some of the flexible regulatory pathways that FDA leadership is setting up are exciting for the rare disease communities. I think they seem to be really responsive to and at least communicating out that they're taking regulatory flexibility seriously for the rare community. So I think that, it's wonderful to see that it seems to be a priority at the FDA, but I'd love to see that sort of hit the operational decisions, making sure that FDA is staffed to the level that it needs to be staffed. I think another really thing we were happy about and excited about is the pilot program that's been set up by CMS for sickle cell disease for gene therapy, the Gene Therapy Access pilot. That's really trying to help state Medicaid programs get their value-based arrangements in place and be able to really clinically deliver this gene therapy. I'm really, want to call out that that's a positive, that is still being funded. Paul, if you have any thoughts on that.
No, I was just going to say, I think you're absolutely right. And I think the system is under a lot of stress and there's a lot of change happening really quickly. And like, for instance, the Department of Health and Human Services has shut down the advisory committee on heritable disorders in newborn and children.
Mhm.
Very unfortunate. I would also say that that's an opportunity for advocates to step forward and talk about what system we want. Because I think everybody would say that there were problems with the previous system, and we wish we could go faster. And wouldn't it be great if every state was aligned to the recommended uniform screening panel for newborn screening? So at the same time, I think we all recognize systems under enormous amounts of stress. Let's ask for what we want, and let's ask for where and let's offer visions for where we think the system needs to go, because I do think that there are people who are listening and we should engage them and do exactly what Erica's doing right now, engaging with your state Department of Health. I think they're going to be really receptive and listening because they're close to these populations and really responsible for them.
I'll just throw out another point at the federal level of maybe a little bit of hope and excitement for what's coming down. The Rare Disease Innovation Hub has been alive and well and has put on a RISE workshop, a point of engagement, and has an open comment federally available right now for people who want to submit comments and who want to suggest future workshops. So I will grab a link to that and eventually put it in the chat when I'm done.
Thank you.
But it's a great point to sort of have your voice heard. Regulatory flexibilities is a great conversation for that space in therapy development and looking ahead. So there's still investment and still those conversations in rare, along with the proposed regulatory flexibilities and few really exciting approvals that we've seen. It just feels really slow right now because there's so much going on, and it's a little bit maybe hard to pick out some of the points amongst all of the everything.
And Dorinda did put some information in the chat about the Ohio Beneficiary Advisory Council, Medicaid Advisory Committee, and the Beneficiary Advisory Council. Thank you for putting that in the chat. I want to switch gears a little bit and ask about copay accumulator programs. To clarify what copay accumulator programs are and the ways they affect people, particularly those managing chronic and rare conditions. I'm going through this myself personally right now and have learned a lot. It's making my head spin a little. Paul, do you have any feedback on that, or Erica?
I wanted to let Bailey weigh in too. I'm sure she could speak
Okay.
to that too.
You can go ahead and start.
As Heather just said, a copay accumulator is basically, and a lot of commercial insurance plans will do this. They will say that any assistance that's given to you by the drugs manufacturer to help pay for the cost of your medicine does not count against your full deductible. So if you have a high deductible health plan, which I think basically almost everyone who has commercial insurance, especially employer provided insurance right now, probably has something that would qualify or be very close to a high deductible plan. That money that's being given to you, or those discounts that are flowing from the manufacturer, are not counted against your deductible. So when that spending runs out, you are still left with your whole deductible, your whole out of pocket. And we could talk about how to fix that, but why don't I stop there and say, Bailey, did I get that right?
You did, and this is a stolen analogy, but I think it's my favorite one so far. It's like getting a scholarship to college, and it covers everything, and then you show up on day one, they've cashed the check from whoever they're getting your scholarship from, and then they still try and charge you your full tuition and room and board and. So that's
I'm going to steal that. That's good.
Yeah, I forget who I've taken it from, so I can't give credit, but it's a really great analogy. And unfortunately, it does lead to a lot of really hard decisions, such as deciding, rationing medication, which is obviously not ideal, foregoing it, or then the financial distress of having to pay all of that up front.
Yeah, and I'll just jump in. We actually in the state of Minnesota had introduced legislation to try to ban this practice for the
We're
very
doing it
reason
in
that
Ohio too.
Bailey. Great. And I think one of the things, one of the talking points for the rare, specific to the rare disease community, what you'll hear is you'll hear payers say, well, we use copays and deductibles to steer people toward more cost-effective medication. So, if somebody has to pay for something, then they'll think twice about using this expensive medication. But I think what I've really messaged to our state legislators is, for the rare disease community, overwhelmingly, we have no other options. We don't have other treatments, and our medications are expensive. So, while we all love the idea of lowering the cost of drugs and treatment, we just feel this is a very wrongheaded and punitive way, especially for the rare disease community. So we've really messaged out that if your goal is to, use copays as a lever to kind of steer people to medications, it is not something that should be used in the rare community because it just ends up being punitive, not something that actually changes our behavior because we have no other behaviors.
It's a great tool if you have cheap generic statins or
Right.
other inexpensive
That
drugs,
are
and you can
completely equivalent
choose
to one
that
another.
are completely basically equivalent. But you're right that for the vast majority of rare diseases, there are no treatments. And for the relatively small numbers that do have a treatment, it's usually a treatment, a single treatment.
Were you going to add something, Bailey?
Paul took it. But yeah, it's really only 5% of the rare disease community that even has an available treatment that's FDA approved. So it's just not always an appropriate utilization tool for this community. And I had something and I lost it, but if I think of it, I'll throw it back in the chat.
And some if you are in your state are work if they're working on this in your state, an organization like Erica's, that most states have a rare disease advisory council, if I'm correct. And so they might be working on it in your state. They are working on it in Ohio. I actually submitted testimony on Monday. Um, um, so, and they helped me walk through it. So I wasn't just on my own writing this testimony. They helped me and helped prepare it to be submitted. Also, Pompe Alliance, we put out on our social media just a couple days ago information about copay accumulators, the definition of what they are, and insurance providers and pharmacies that do not take them. And I use CVS and have United Healthcare, and neither one of them take it. So you can see that on our social media. Yes, I see Bailey has her hand up.
Yeah, I figured out how to raise my hand. Also, this is just a pretty important issue on both the state and the federal level. So this is one of those opportunities where you can use the same information or very similar information to advocate with your federal legislators as well as your state and create some of those connections in both spaces. So that was just the last tag in.
Thank you. The next question, still along those same lines, are about alternative funding programs. And can we talk about what they are and how they influence patients' access to care, and again, especially for those with rare and chronic diseases? Bailey, can you speak to alternative funding programs?
That one's a little bit more outside of my wheelhouse. So I don't know if Paul has
Okay.
a second.
Okay.
I will jump in. So the alternative funding programs are essentially third-party programs that will go to an employer-sponsored plan and say, if you exclude a rare disease or even all rare disease drugs from your formulary, what that will do is we'll send a patient with a rare disease back to a patient assistance foundation that's operated by the manufacturer where they can get free drug. And the pitch is that this will reduce the cost to the employer, and the AFP, the alternative funding plan, the employer will split the savings. The problem, I think, from several dimensions is that this really undermines the whole point of having insurance for serious and chronic diseases. The whole point of insurance is to cover unexpected large catastrophic costs, and the manufacturer's plans are typically meant for low income people who don't have access to insurance. So it's meant to serve people who have no alternative means of coverage or paying for a drug. So, I think it's problematic in a few different dimensions, one of which I already spoke to about insurance, the other which I think there's some concern that it could be discriminatory because you're targeting it at people who have serious and chronic illnesses, including orphan diseases. And in the long run, you're putting a lot of concern into patients that they have to jump through hoops. The dirty little secret is that if you can't access the manufacturer plan, that AFP will turn around and get you funding through your employer's plan. But the real risk then is you wind up going without treatment for some period of time. And as was already mentioned, rare disease treatments are very expensive. And you don't want to put people in that situation of financial distress or fear that they're going to go without a life-saving or life-extending medicine for themselves or for their loved ones. So this is not how the system is going to work. And Bailey spoke a little while ago about some innovative financing, for cell and gene therapies. I think there's a lot of promise there. I would say that these AFPs is not the right way to think about rare disease coverage.
Thank you. I want to go back to Paloma, and we talked about this a little bit. But as a designated family caregiver for a child with a rare disease, how might the proposed budget changes directly impact your ability to provide care and access to necessary resources?
So personally for us, it doesn't feel as emergent. Our state, while Pompe is an automatic qualifying diagnosis for Medicaid, it actually isn't that simple. For the state of Kansas, you still have to meet a certain household total income threshold, which we exceed. So even though we have 2 children with the diagnosis that is an automatic qualifier, that did not give us access to said Medicaid, and not even as a secondary coverage, which is unfortunate. I have since this year joined the workforce in preparation for some of these changes, so that I have a state employee plan that I can have access to now, along with my husband, who currently and has for for all of their lives carried insurance for them. So we're sitting in a spot where we don't necessarily feel too impacted. But that doesn't mean that just because the prices for 2026 are locked in, that if these increases continue to go, that's not going to be something unattainable in 2027, 2028. And again, they are always going to need insurance to be able to do what they do. So while it doesn't feel emergent, it feels like something that definitely is just going to sit here kind of nagging us until we come to that point where it is. If that makes sense.
Yes, it does. Thank you. Are there any provisions in the new budget that will have negative impact on family members that are designated caregivers? Does someone feel like they can answer that question?
I feel a bit redundant, but I'm going to say it again. It's those work requirements. It's making sure that you're enrolling in time, and I know caregivers have that burden for a lot of folks. So, really just keeping up with the paperwork and keeping up with the requirements is going to be so very necessary to ensure a continuation of care.
Thank you. Paul and Bailey put a couple of resources in the chat also. Thank you. And this is maybe a question for Bailey or Paul, maybe even Erica. Could you can you speak to how this budget would might affect government funding for clinical research for rare diseases?
I'm going to let Erica take that one.
Yeah, so I don't have the specifics, but I know one area that we had a lot of concerns about was government funding of some of the RDCRN networks that are at the NIH. So the Rare Disease Clinical Readiness Network, I think is what it stands for, through the NIH. I chair a consortia of patient groups for one of them, and this one is managed through the Children's Hospital of Philadelphia. We were able to get that grant administered, and so we are continuing that kind of research consortia. I don't know if all of them were able to get their funding again, but I know it created a lot of uncertainty. I know certainly there's grant reductions at academic centers, and so we know in rare diseases the federal government has an outsized role to play in funding research so that they can de-risk some of the drug development. And I don't know if anyone, maybe Paul, you have the number, but I know that for every dollar that the government spends on research R&D, it generates money in the private sector as well. I'm not exactly sure what those numbers are, but I think
have that number written down.
Oh, very
I
nice,
do.
Heather.
It was something like, oh man, I wrote it down. Oh, so what I have is for every dollar spent by NIH, it generates $5 for the local economy.
Wow.
And
Yes.
I got that at a I don't maybe that was Rare Disease Week on Capitol Hill.
Well,
That
well
that
done.
was
I
in
did not
February.
have that. So yeah, I think that's a really important call out that, the reduction in spending on research and development at the NIH has, as you just so eloquently said, it has, far-reaching impacts on the community. And again, just calling out the reduction in the personnel to be able to administer some of these programs and award these grants in a timely fashion. Paul mentioned too the dissolution of the newborn screening committee at the federal level. That also will have impacts on the ability to add diseases to the recommended uniform newborn screening panel. So yeah, real concerns there, particularly given the fact that rare diseases have so few funding streams for research.
Thank you. And please, if you have questions, please raise your hand, put them in the chat. We want to make sure we get if you have questions, we want to make sure you get them answered while we have this wonderful panel together. Again, we have people monitoring the chat and looking for raised hands. So please, if you have questions, just throw them out there.
I'll tag in a little bit to what Erica was just saying for research, at least with this sort of upcoming appropriations reconciliation cycle that we're looking at. NIH funding was, I think, surprisingly higher than most people expected from both the Senate and the House. And it kept the current structure of NIH. So I think a while ago we were hearing about potentially restructuring and changing sort of our center, the different offices that are at the NIH. And so both of those proposals kept it the same, had a decent value for it. I don't have the numbers right in front of me. And then neither included the sort of indirect cost cap change that we saw before too, that was causing a lot of concern. So maybe a little bit of hope there.
Thank you. I really would like to open it up to people in the audience if you have questions. We were trying to leave some time towards the end of the meeting, and we've got about 25 minutes left. So I really want to make sure if you have questions, we're able to address them. Did you have something to add, Bailey?
Oh, no, I just never
Oh,
remuted.
okay. Carmen says it is estimated that $1 increase in publicly funded basic research stimulates an additional $8 plus of industry R&D investment after 8 years. This comes from a 2024 report titled The Economic Case for Public Investment in Stem Cell Research, published by the USC Schaefer Center for Health Policy and Economics, but wasn't limited to stem cell research. Thank you, Carmen. That's good information. So I have another question. If no one, I'm going to put it out there before I ask this question, if anybody else has anything before I ask it. So I'm going to ask this question to you, Brad, because this was something that my dad and I heard about in a meeting where we met one of your colleagues back in September. They were talking about retroactive coverage for Medicaid recipients. So can you
Yes.
talk about, can you explain what that is first, and then talk about how the new bill might affect retroactive coverage?
Absolutely. So, retroactive coverage, essentially, it means that if someone becomes eligible for Medicare, the program could cover up to 3 months. Well, that's what it was previously, up to 3 months before their date of application. So it really gave you a good amount of time to be able to apply, but then also to get that coverage or that care that you had before you were approved 3 months prior. So as far as that goes, under the current law, many states must have covered up to 3 months. That I believe is going down to just 1 month. So that obviously limits the coverage that you could get covered. But it's coverage overall. And it really puts folks in a bind. Sometimes it takes even more than a month to even get through the application process. So really that helped out a lot of folks, that 3 month window, and to cut it down to one, it's just another way of limiting care.
Thank you. And I know we talked a little bit about work requirements under Medicaid. Can maybe Brad, again, I'll start with you. Could you explain what those work requirements will be under this new bill?
So I don't know the numbers offhand, but essentially, if you are in between the ages of 18 and 64, with some exceptions, you will indeed have to provide some work requirements. Please correct me if I'm wrong. I believe the number is 20 hours. Does that sound familiar to folks? 20 hours is what I believe the number is. That could either be work requirements or it could be volunteer opportunities. So we are essentially trying to work with the different nonprofits here in the Cleveland area to see who can provide those hours for folks. And perhaps, if this is something that the state's going to force upon us, we could at least get some good assistance when it comes to the food banks, or if the local May Dugan Center could use assistance. Really, the folks that could help them with that paperwork, or that could see those problems coming, we can try to fill in some volunteer hours while at the same time satisfying the Medicaid hours. But ultimately, it's just one of those things that, can you imagine sending someone who's 63 years old back to work or back to volunteer? It's unfair. It's inhumane. It's disappointing that this kind of thing not only has been proposed, but has been passed.
Thank you.
Sorry, I was
I was
just
just
going
going
to
to say
add
Bailey put some links in the chat. Go ahead, Erica.
and I was just going to add that, this has been implemented in the past in other states. We know it doesn't work, and we've seen it before. So this is, it added administrative burden and to states, and it was really just not an effective strategy to, as John said, it's kind of the general assumption itself to me is flawed, that people have to earn their Medicaid and work as a work requirement. So definitely something that I hope the community can message back to our leadership that it's just not a good proposal of policy.
And just to tag on for exemptions, folks still have to prove the exemption, and it's still a continued form of it's every so often you have to prove that you still qualify for the exemption. And I was reading something this morning about how states have no idea how they're going to implement that. And some were trying sort of a text format, some were trying apps, and it's how do you do that? How do you keep everyone's privacy? How do you stay compliant with that? How do you actually reach everyone, especially in rural areas where folks might not have, cell service or great phones? So it's creating a whole slew of problems and just the logistics of implementing it.
And even these county offices, they are looking at this new increased burden. They have trouble keeping up with the applications as they stand now. To add another layer of bureaucracy to their already understaffed, overworked offices, it's just a recipe for disaster.
Go ahead, Vanessa. I'm sorry.
I was going to say we have a question in the chat.
Oh,
Okay.
and Heather, I apologize. I just wanted to step in. I actually have to go drive my daughter to a high school visit this
All
evening,
right.
so I'm going to have to sign off a little early. But thank you so much for
Okay.
inviting me. This has
Thank
been a
you,
terrific
Paul.
conversation.
Thank you for your participation.
Thank you. Take care. Have a good night.
Bye-bye. You too. Kate wants to know, do we know if individuals with disability will have to meet work requirements and reapply every 6 months for Medicaid?
I might be able to take this one. Again, it is going to be by a state basis. So, based on where you're at is going to be the rules. Hopefully there is going to be some type of list or exemption for folks that they can prove that they have a permanent disability. I'd imagine many states are not going to provide that type of exemption. I imagine that even those that are permanently disabled are going to have to prove that they are permanently disabled twice a year. Again, these are just cruel policies to limit care.
And my dad said again, and this is again probably for the state of Ohio, because this was information that came from that meeting we attended back in September, that it was 80 hours a month.
80,
work
okay.
work requirements for that's again probably for the state of Ohio.
Heather,
Yes.
it's 80 hours of either community service, work, or being in an educational program.
Okay. Yeah. And again, that's for the state of Ohio. The program, the meeting we attended, they were talking about the Medicare, Medicaid, actually Medicaid and SNAP were what they were talking about for the state of Ohio. Okay, so I want to switch gears a little. If we don't have any other questions, and again, if you still have questions throughout, just put them in the chat. We're monitoring. But as we're coming to a close of our meeting, I want to try to talk about some positive things and how we can look ahead and stay engaged and involved. So I'm going to put this out to all of our panelists. What are the most urgent actions the rare disease community should take in response to the budget bill? So I'm going to start with you, Paloma, as a caregiver, as a mom, and an advocate. You have two roles.
I think when I first got into advocacy, I felt a little like, what is the point? Why does my story, like how does it mean anything? It's just my story. But as you go further along in this and you're building more relationships, you really learn that people only know what they know. It's our responsibility, or maybe look at it as it is our privilege to talk about the extraordinary things that we do within the rare disease community, because we are witnesses to miracles daily. And some people don't have that privilege. And so I think now is really the time to not be fearful or think that my story is insignificant. It is powerful. And the more that we can communicate what happens in our lives, the more that we create dialogue, and dialogue creates change. And without that dialogue, um, people will only know what they know. So I think really like instead of shoving that fear down, let that fear be vocal and talk about why, and what your hopes are and what your needs are. Because again, without dialogue, there's no exchange.
Paloma, can I ask you a follow-up question
Mhm.
to that? I often hear people say, nobody wants to hear my story, or I don't know how to advocate. So what did you do to learn, if you will, how to be an advocate?
I took my coaching philosophy, and I put it into practice with this. So the very first time that we were able to share our story and bring Vaughn to a state legislator to talk about why adding Pompe disease to the newborn screening panel in Kansas was so important, we failed. Um, and it felt really hard, right? Like, man, I totally fucked this up. I'm never going to get this opportunity again. Uh, and on the car ride home, instead of just being disappointed, we started having the conversation. Well, where did we lose? How did we like disengage them? And so you have to really think about first and foremost, you want to let the passion have feel comfortable crying in front of people, but then tie it back to something that is meaningful to them. So the way that we tied it back was they said and had tears and applauded and said, we're so happy for your son, but we don't have $2 million to add to this. So we went back knowing that that was their priority. And how do we tailor our story to be of some language that meant something to them? So when we were able to come back the second time and discuss this, we talked about our son as a kindergartner and one of his friends as a kindergartner who was clinically diagnosed, and the challenges and supports that they were going to need in the school system starting as kindergartners, and that was going to have to follow them through 12th grade. And so once we tied that back to this idea of the 2 million and then realizing, well, every Pompe kid that we don't diagnose that has, the worst case, that's easily going to be more than 2 million before they're out of elementary school. And so that really just really taking those moments as failure and not feeling like failure, but using them as opportunities to, how do I tailor this? How do I get better at it? How do I get a little more comfortable? I think when you're doing this, be authentic, but then also know about your audience and who you're talking to.
Thank you. Erica, I'll ask you, what's the most urgent actions the rare disease community should take in response to this?
I think what comes to mind and what we're really trying to help people do is, find that community and get involved in the community for so many reasons. One, because it gives you that support. You're not alone. You can, band together. I know that if I know one thing about people with rare diseases, it's the resilience of this community. And this is not the first time we've faced odds. This is not the first time that we've had to deal with setbacks. And so I think urgently, find your center, do not be discouraged. And then also I think be disciplined. And I think one of the things that's so hard right now is it's just, there's kind of just shell shock because everything's coming at us, right? All these changes and unpredictability of the system, but really just try to stay grounded and be involved and connected to the community. In that way, we can act collectively and not individually. And I loved what Paloma said, in terms of telling that story. I think one of the things to remember too is always have an ask ready when you tell your story. What is that tangible thing? Legislators So many legislators across the political spectrum want to help, they want to hear, but they also sort of need to know what they need to do once you tell your story. So having a tangible ask that is within their power to do, like Paloma said, know what's in their scope of ability and their scope of action, and be ready to ask them for what you need.
And I always um, encourage people to attend Rare Disease Week on Capitol Hill. That's a really great event. I always say to people, it's the hardest thing, one of the hardest things I've ever done, but one of the most rewarding. And Every Life Foundation and Rare Disease Legislative Advocates really prepare you to speak to your representatives. And that's really what got me involved, was attending that event and meeting other people. And I met Paloma for the first time at that event. So I always encourage people to attend that. Bailey, I'm going to ask you a different question about looking ahead. How can we ensure that rare disease voices are not just heard, but prioritized in future policy discussions?
Yeah. I think it really goes hand in hand with what Erica and Paloma were just talking about. And I will default to your story for a second, but that truly is what makes the difference. And that's what takes a lot of these issues off of paper and just something that people are discussing in this abstract sense. And when you put a face to it and a voice to it and someone's experience, and you can connect that with data, and you can connect that with something that helps convince and show on paper why they should or shouldn't make a decision, it really becomes this well-rounded, I hate to say this sounds manufactured, but package. And it creates this moment where someone is now emotionally invested and intellectually invested, and they can make sense of everything of how it translates from this piece of paper to life. I think there's also really a sense of relationship building. And so, and I started off with this, but right now we have a really unique opportunity where a lot of decision making in the spaces that we care about is shifting from being so heavily federal. Federal is obviously still involved, but the states are going to be involved in a different way than they were before now. And it's a lot easier to meet with someone in your state and set up that meeting and create a personal connection. Maybe you know someone who knows them. And it doesn't just have to be about what's going on with HR1 right now in the budget. It could be, if your concern is about getting coverage for your therapy, maybe setting the grounds. There hasn't been a decision made yet, but you want to set the ground so someone understands that FDA approved rare disease therapies aren't experimental. They're, rigorously reviewed, and they're safe and they're efficacious. Have that conversation. If you want to have the conversation about your Medicaid and access, or your community and considerations for that, plug in with your state's BAC, the Medicaid Beneficiary Advisory Council I mentioned before. So it's both like finding your community and then sort of, I think, meeting people where they are a little bit, and having those conversations. And if the idea of going to a meeting is daunting and scary, but you still want to share your story, there's usually opportunities to submit comment, whether that's federally or at your state level when there's decision making. You sort of have to know where to go to find it, and plugging into some of those organizations, or just going through your state's Department of Health website and figuring out exactly where they share that information is a really great resource and a way to find that. Or you can even go to social media, right? And maybe tag some places. A lot of people are doing that now, and it feels a little bit easier and a little bit less daunting than finding a meeting. And I will plug, find your community, find an organization that you really do trust, to echo Erica. I personally love the resources that Every Life puts out. And I'm not just saying it because I work there. I do think they're truly great resources. Our RDLA group hosts a monthly webinar where people can come listen to the topic of that month. We had one on HR1 earlier, and then we had sort of a general update in September. Our next one is October 30th. And the link I put in the chat earlier can take you there. Or if you know another great organization that puts out data that has policy primers, like, leverage resources that already exist. You don't have to reinvent the wheel just because you're doing it now.
Muscular Dystrophy Association is another one, and they often have pre-written letters, and all you have to do is sign your name to it, and you can add a little bit about yourself and your experience, and then it just goes off in the email. and what is it? House.gov helps you find who your representatives are. And Brad, you can probably talk about that too, and find your representatives and send emails also. So I'm gonna ask you that same question, Brad, about how can we ensure that rare disease voices are not just heard, but prioritized in future policy discussions as we're ending our meeting.
Sure. Ditto to everything everyone just said as far as tell your story, develop your ask, find your people. There is strength in numbers overall. To be completely honest, utilize the opportunism of elected officials. Um, Elected officials are looking for opportunities to champion your story, but also to make sure people see them as a champion of your story. So if you do have a good story to tell, if you've got a great group of advocates that are coming to visit the office, let them know that you would like to participate in a press event or a social media post, or let them know that your story should be shared far and wide. If they see an opportunity to have a public event with a large group that can amplify to not only their people, but then we can amplify to our district, that really is an opportunity that many elected officials will jump on. So essentially, if you're building the event for them, it's hard for them to say no, unless, of course, they're for some reason opposed to this kind of thing. But I can tell you that that definitely stands out when we get an email that says, "Hey, I've got the doctor, I've got the patient, I've got the advocate, and we want to come talk to you about this, and we would really like to be able to do social for it." That's the kind of thing that we will take that opportunity, as it is, pre-built, but it also is a good way for us to get our name out, but for us to be able to champion your issue as well. So again, I apologize to admit to the crass opportunism of elected officials, but lean into it, use it.
Thank you. Oh, so before we jump off, people that outside of the panelists, and there's a few of us with Pompe Alliance on the call. If people could just drop in the chat the city and state they're watching from, we'd greatly appreciate that. And so we're coming to the end of our town hall. And I just again would really like to thank Bailey, Brad, Erica, Paloma, and Paul, who jumped off early for attending and giving us the benefit of your expertise and knowledge, and Paloma, really like speaking from the heart about your experience. I know it's not always easy. And so I appreciate everyone being here. And I hope everyone found this to be very helpful. And if you have questions that maybe didn't get answered, if you want to shoot me an email, it's pompealliance@gmail.com. And I'm happy to try to connect you with the right people. And if the panelists don't mind, if you don't mind sharing your contact information for the people in the meeting, if they have questions, if you don't mind sharing your email or that sort of thing. So again, thank you so much to everyone who has participated. I really hope this was very helpful. I know I learned a lot this evening. So again, and thanks Erica Erica kind of came in last minute. So I appreciate your time. Thank you everyone. And
Thank you
have a
so
good
much.
evening.
Take
Thank
care.
you.